Let's talk about intracranial aneurysms. So an intracranial aneurysm is thought to be created due to hemodynamic stress on the vessel wall, which causes breakdown of the internal elastic lamina. And so because these walls are thinner, they start to have outpouching, and this is an acquired condition, and that's what forms the aneurysm. So predominantly, these aneurysms form in the anterior circulation, with the anterior communicating artery being the most common site. That's a commonly tested question. And the risk is increased in first-degree family members of people who have intracerebral aneurysms. And there are also some other diseases which have a high risk factor for causing these aneurysms, such as autosomal dominant polycystic kidney disease, glucocorticoid remediable aldosteronism, Ehlers-Danlos syndrome type 4, and pseudoxanthoma elasticum. There are a few different types of aneurysms. The more classic type is the saccular or berry aneurysm, and these are the thin-walled aneurysms that look like outpouchings, and they have absent tunica media and or internal elastic lamina. The other type is called fusiform aneurysm, and this is a dilatation of the entire circumference of the artery. And there are also mycotic aneurysms, which are aneurysms that form due to infections, such as from infective endocarditis. So normally these aneurysms are asymptomatic, and they are incidentally discovered from head imaging that is done from other reasons. Other times you can have symptoms that are thought to be caused by mass effect, such as headache, visual acuity loss, or cranial neuropathies. One important concept is that you can have a third nerve palsy from a posterior communicating artery aneurysm, and this is because the posterior communicating artery runs alongside the oculomotor nerve. So this can be a cause of blown pupil. And rupture of these aneurysms causes a subarachnoid hemorrhage. So in terms of screening, if someone comes in and they have 2 first-degree family members that have had intracerebral aneurysms, or if they have any of the associated conditions, autosomal dominant polycystic kidney disease, glucocorticoid remediable aldosteronism, Ehlers-Danlos syndrome type 4, and pseudoxanthoma elasticum, then any of these people can be screened, and the typical screening modality is MR angiography and CT angiography. Either can be used. So let's say someone has been diagnosed with an aneurysm. So when it's unruptured, you want to focus on reducing the risk factors that make it rupture, such as managing hypertension, as well as smoking and alcohol cessation. For small aneurysms, they can be monitored serially, let's say every 2 or 3 years. And for larger aneurysms, such as for those over 7 millimeters in diameter, you can consider coiling or clipping as the treatments. Coiling is an endovascular procedure, and you can also stent it at the same time sometimes. And clipping is a surgical procedure. Coiling may have a lower morbidity and mortality depending on the center that's doing the procedure. In terms of prognosis, larger aneurysms grow faster than smaller aneurysms, and larger aneurysms also tend to rupture and have a higher risk of rupture than smaller aneurysms. Specifically, at a size of 7 millimeters and greater, the risk of growth and rupture starts to increase.